everybody then. Nice to see you. This is my second visit to Leicester University today. I feel very humbled that I can come here twice in a day. I've been let out of the hospital for a bit, so that's always quite nice when you have a travel out. So lovely that you all came as well, so that's really nice. My background, just to let you know, is as a clinical dietitian. So I trained as a dietitian way back in 1986, which was a very, very long time ago. And then I worked at the Leicester General Hospital. Does anybody know the Leicester General Hospital? Well, I started off in a porter cabin, so that's where I started off, in a porter cabin, which is now, it's still there actually, but a bit derelict. It was due to be condemned a long time ago. And I started off in what is now a stationary cupboard. So I've moved high in the world now that I now have my own desk and a room, and the hospital has moved on. But it's lovely to come to these lovely facilities and meet you. So my plan then today is I'm going to talk about diabetes. I'm assuming some of you have got an interest in diabetes, and that's why you've come. So you may have diabetes in your family, you may have diabetes, you may be thinking, I don't want it, and what can I do? So my plan is to do a bit of an overview of it really, and then have time for questions at the end, because often people get more from the personal questions that they bring to the session. So we're going to look at setting the scene a little bit. What is diabetes? Check we're all clear with that. What's the consequences of getting diabetes? What are the risk factors? How can risk be assessed? So how would you know if you were somebody who is high risk? What are the signs and symptoms? How can you reduce your risk, and what support is there out there? So hopefully some of you might be able to help each other on that also. So the plan. In the UK then, some of you will know this, we hear all from news all the time, don't we? But actually the number of people with diabetes actually doubled over the last 20 years. So now you hear all the times on the news, don't you, about, oh, diabetes is going to bankrupt the NHS, we're all, what we're going to do. 1 in 15 people actually have diabetes. So if we look in the room, a couple of us probably would have diabetes anyway. That, in another way, means 4.7 million people with diabetes. And would you believe that someone is diagnosed every 2 minutes? So we've already had a diagnosis going off somewhere. That equates, those figures are actually more recent, that 2000 that should be knocked off. These have been updated, the most recent figures. So £5.2 billion per year is spent in the NHS on diabetes, which is equivalent to 192 million per week, 27 million per day, 1 million per hour, 19,000 per minute, and £315 a second. So it's quite an expensive condition, hence where the government is now getting very into prevention as a part of its dealing with the disease. So what is diabetes then? I bet you've all heard a lot about diabetes, have you? Yeah? Basically it's a condition where there is too much glucose or sugar in the blood. So do we all have sugar in our blood? Yeah, so we actually all need some sugar in our blood, but actually it is when it is higher than normal levels that we start to diagnose and classify as having diabetes. We actually need some glucose in our bodies, and actually what we've got to remember is that every single minute cell in the body, wherever it might be, needs glucose 24 hours a day. So we need to be able to get the glucose from out of our blood system into the cells to be used as energy. And that is done by the pancreas, which is the organ that actually makes insulin and sends it everywhere to be helped to get the glucose where it needs to get. So insulin is very much, as an analogy, is very much the key that opens the cell door that allows the glucose to get from the bloodstream into the cell to be used as energy. Is that okay? So we have different types of diabetes, but basically the problem is with insulin. Either we're not making enough insulin, or there's actually something that the key isn't working too well, and we often talk about rusty locks. And rusty locks, the medical term for rusty locks is actually insulin resistance. So there's some things we can do to WD-40 that lock, but there's some things we can't do. So diabetes is not all the same. You'll have heard about different types of diabetes, but overall it's either due to either not enough insulin or it not working well enough. So type 1 diabetes you'll have heard of, that is the condition where there's an absolute no insulin production anymore. So what do you think the only treatment is for type 1 diabetes? Insulin injections. And actually my husband's had insulin type 1 diabetes for over 50 years now. So when he was born and when he got his diabetes age 10, in those days, people were not expected to live that long, really. And actually now people get medals for 50 years, 60 years and 70 years. So a condition that was once thought to be incredibly dangerous and you wouldn't have a long life is actually changed by the new treatments around insulin and insulin therapies and pumps. Type 2 diabetes is associated with either insulin resistance, so those rusty locks, or something to do with beta cells in the pancreas that produce insulin not working too well. Okay. Do you think all type 2 diabetes is the same? No, we used to all think it was all the same, didn't we? And there was only one type of type 2 diabetes. But have you noticed that some people with type 2 diabetes are very thin and some put weight around their middle? So we shouldn't really treat all people with type 2 diabetes the same. Those who have what we call a bit of central obesity actually need to manage by diet and certain tablets. Others will progress more quickly from tablet to insulin. And there's a different sort of pathophysiology for that.
I have to stop you there, because you've said some people will need this kind of tablet and some people will progress this.
Yeah.
But my concern is there is not enough public knowledge and understanding of how type 2 diabetes can be managed by diet and exercise.
Absolutely.
And I just wanted to make
so I will come to that, but no. Yeah.
It was almost like a foregone conclusion, or you're saying it goes to that, and it needn't be.
No. I will get to that, but I have to say, it's been a joy that in the last few years people realise that there is something we can do. Because back in 1994, when I went into diabetes, there was a very, very big study called the UK PDS study, and that almost said that diet failed within the first 3 months of diagnosis. So it was a very big study, and what happened from that was that because lots of clinical people thought, oh, diet's not going to work, they started to medicalise type 2 diabetes. And from my experience as a clinician, we saw people move very quickly, not being given much chance with diet and lifestyle. They were put on tablet, another tablet, and they were progressed to insulin very quickly. Now, thank God, we've realised that that doesn't have to be the way and there's things we can do. But actually that study, whilst a very, very good study, actually did lead to diet and lifestyle being something that wasn't actually given much importance.
And do you mind me also saying that until relatively recently, one of the barriers to that understanding was that there was very poor information even on Diabetes UK and on the nicer websites regarding the diet that was helpful. So I mean that's one of the reasons.
Yeah, would you all agree on that? I think one of my and some of the people who work at the university, one of our concerns is around enough information being given to people to be able to self-manage their condition. Because actually what we know is that knowledge alone is not enough. You need some skills and some support to work out what's best for you for that. So basically everybody's different with diabetes, and actually unless the clinician looks at what diabetes you've got, they can't treat everybody the same. But traditionally that is what used to happen. So we do have type 1 diabetes, as we talked about. We have type 2 diabetes, which often we thought was for those who were over 40, and we thought type 1 diabetes was for the under 40s. However, now we're seeing people get type 1 diabetes age 90 because they live longer, but we're also seeing type 2 diabetes. I saw an 8-year-old, I've been looking after an 8-year-old with type 2 diabetes, which we never had type 2 diabetes in children before. So there's something going on that's mixing and clouding the area. Gestational diabetes is the diabetes you get in pregnancy. If you get gestational diabetes, you have a 50% chance within 10 years of developing type 2 diabetes if there isn't some information out there. And we know that's another area where people haven't been supported post-pregnancy to actually do something about their lifestyle to prevent getting type 2 diabetes. And other genetic conditions exist, but the main types are really type 1, type 2 and gestational diabetes. So the consequences are only if type 2 diabetes or type 1 diabetes is not managed well. If it's managed well, we know that actually you can prevent complications of having type 2 diabetes. But the problems tend to be that you have stickier blood vessels. So often with type 2 diabetes, many of you who've had type 2 diabetes will recognise a bit of a package comes together. So you often get high glucose levels, blood pressure and cholesterol issues, and actually that's just linked with that rusty lock syndrome, insulin resistance. So sometimes people feel I've been diagnosed with diabetes and now suddenly my blood pressure is high and suddenly I'm on tablets for my cholesterol, but it's because we're risk reducing, because you wouldn't actually have symptoms of high blood pressure or cholesterol until it was a problem. So that's why doctors check you more regularly nowadays. Obviously, if you have high blood pressure and high cholesterol, then we're worried about heart and stroke, so that's why we're risk reducing those. If glucose has floated over nerves for a long time, then sensation can go. So it's not that that's a problem, it's just that if you don't check your feet, then actually then damage can happen. But with good prevention, these problems don't happen, and over the years that's completely changed the amount that happens, but that's again down to education and understanding to check your feet and not put your feet into shoes that don't fit, and if you get a blister, take your shoe off. Eyes, hopefully all of those of you who have type 1 have diabetes of any form will go and get your eyes checked. It's slightly different to a usual eye test. What they're doing is putting drops in your eye so that you can look to the back of your eye. They're looking at the retina, and what they're looking at is the tiny little blood vessels at the back of the eye become very fragile, and we're just trying to make sure that they are well. Lots of people have a little bit of background damage, but that does not mean there's a problem. But if you're screened, then you can get that dealt with, so it doesn't need to cause a problem. Depression, why do you think depression is common with diabetes? It's a lot of balls to juggle, lots of things we look at. You're often going to healthcare professionals who are telling you off or saying this or that and feeling very judged. So many people find it overwhelming, so we do know that depression with any chronic disease can come in and out, and it's about trying to get help and support by friends or family or clinicians if need be. And the little one with a sad face is actually one of the long-term effects for men with diabetes can be erectile dysfunction. That is something that is not often talked about, but your clinician should ask you every year if there's a problem, because again, the reason they do these screening checks is that there's something they can do about it. But if nobody talks about it, then everybody thinks it's okay. But if you've got nerve damage, then obviously that will affect all aspects of the body. So risk factors. Ethnicity, can you do anything about your ethnicity? No, so that's a risk factor that might be there, but you can do absolutely nothing about. Can we do anything about getting older? No, so that's another risk factor that we can do nothing about. Oh, that's family history, sorry, I have to guess which picture it is. These are my colleagues who's done the pictures. So family history, if you've got a family history, is that a risk factor? Yes. Yeah, can you do anything about your family? You might want to, but you can't, can you? Yeah? Getting older, as a population, we're all getting older. So that is a risk factor, but can we do anything about that? Certain tablets, such as steroids, some people have to be on steroids because they have a long-term condition. Can you do anything if you've been advised to go on a steroid? Can you do anything about that? No. So therefore, that is a non-modifiable risk factor some people have to have. If you put weight around your middle rather than around your bottom, the type of fat that goes around your organs, again, increases that insulin resistance. So that's a risk factor. It's not easy to do anything about that, but is there some potential, something that you could do about that, do you think? Mm-hmm. Yeah, so it's a modifiable one, so it's something that you can do something about, but it's not easy. If you have, if you're a man who's European, white European, 37 inches, if you're in old money like me, greater or equal than 37 inches is a risk factor. For women, greater than 31.5. So if you're measuring it around where your belly button is and going around mid-hip, mid-waist, that's where that is. If you're South Asian, unfortunately, as a man, you have to be slimmer because South Asians are more at risk at lower sort of levels. So that's a risk factor that is potentially modifiable. Poor diet, so whatever that might be, whether it be processed food, lots of sugar, lots of fat, whatever, anything in moderation is absolutely fine. But what tends to be happening now in the country is that fast food is much more available, isn't it? If you look at the younger generation, if we look at why children might be getting type 2 diabetes, they're less active nowadays and probably more sort of availability, isn't there, of fast foods, nice snacks, which is why the government is addressing so much on a national level, all sugar in products and fast foods. And being inactive, again, we know more about that now as being a risk factor for developing type 2 diabetes. If you have depression, we know that that sometimes can be a risk factor, and stress is actually long-term stress, not just the odd day, but continued stress because you're producing cortisol all the time. That can be a risk factor. If you already have been picked up with having high blood pressure or high cholesterol, then that is a risk factor because of this package for type 2 diabetes that comes together. Type 1 diabetes, the only risk factor might be that we don't really know why it happens still. After all this time, we don't understand. Something happens that destroys the beta cells on the pancreas. So actually, even if we knew what the risk factors were, there's not anything we can do at the moment to prevent it sort of happening. So there's a slight genetic risk, but it's not as genetic as type 2 diabetes. That's a horrible picture, isn't it? But that's actually a pancreas. So if you've had pancreas problems before, I think you mentioned your mother, didn't you? So if there's been anything that's damaged the pancreas, then of course that puts you more at risk of developing type 2 diabetes, potentially, if it's affected your sort of cells that produce insulin. So that's a risk factor that she could have done nothing about that, could she? So that's another risk factor. If somebody's had gestational diabetes, then again, that's another risk factor. So some risk factors are modifiable and some are not. And it's a little bit about thinking about how many risk factors do you have and how does risk stack up. So if you only have one risk factor, the chances are you're unlikely to develop type 2 diabetes. However, if you're getting older, you're of South Asian origin, you sit a lot, your diet's not so good, you've had gestational diabetes, your blood pressure's already high, there's quite a lot of risk factors stacking up. So it's about knowing your risk and then working out what you can do about that to minimise that risk. That makes sense? So some people are very thin, they're very fit, and they say, why have I got diabetes? But actually they might have a very strong family history, that might be their ethnic group, and they might be 70, but very slim, active 70-year-olds. Yeah. Makes sense? Because sometimes people feel very like, what's happened? Why have I got this? But it depends on that whole package. So you can use a risk score to see if, what your chances are of developing type 2 diabetes. And on Diabetes UK website, if you go on that, you can click and it takes you through a step-by-step process. I've got the link, well, I don't think it'll do it on this, to link on it, but there's no, it won't. We're not that clever here. Well, I'm not. But if you go onto the Diabetes UK website, you can go in to do a risk yourself, and you'll see that the main risk factors it's looking at are really age, if you've got a family history, if you've had high blood pressure, what your waist is, because they're the biggest drivers of the risk. There's also a Leicester self-assessment score, so you may find in some of your surgeries that they have this. We often give them out at health promotion events, that there's sort of an assessment that you can use. Sometimes places like Tesco's or supermarkets have risk scores, so it's just to see how you are and then work out whether you feel personally that you have something that you can change or things that you can't change to manage that risk. It actually doesn't matter if you get type 2 diabetes as long as you know you've got it. In the old days, people never knew they had diabetes, so they used to turn up where I used to find people with type 2 diabetes who were going to surgery, and the surgery was cancelled because they didn't know they had diabetes, and somebody did a blood test and said, oh, did you know you had diabetes? Because not everybody knows they have problems, but if we screen people and get people early, then you can prevent problems happening. If you don't know you've got something, then that's where the risk
May I ask another question? Has the ability to be diagnosed early changed in the last few years? Because I am type 2 diabetic. Yeah. I knew all along there was a family history. I knew from my symptoms I had it, but I had the devil's own job in actually getting diagnosed, because what was happening is you were getting a random blood glucose test and it wasn't showing up as a high enough level, but I effectively had to do it in such a way by loading the night before that my score was high enough, which
sounds like some other people are recognising that, are you as well? Yeah.
And in order to have the glucose tolerance test, and obviously the glucose tolerance test was, and straight away it came out, and it was, not borderline, but absolutely there. And I had been fighting for probably 7 years the symptoms, knowing full well that everything I knew said that I'd had it, but I couldn't get over that barrier until I made the decision.
That sounds really tough, but
yeah.
I'm sad to say that actually that does sometimes happen. I think the positive thing that starts to happen in the UK now, which has only happened probably in the last 2 or 3 years, is that there's been a governmental change. I'm looking at that chat. Because when I was interested many years back, and it was probably in about 2000, I got interested. We were doing a big screening study in Leicester called Star, and we were going out with a double-decker bus, and we were just randomly screening people. And we were like picking up loads of people who had diabetes that we didn't know about. But also what worried me is that we were picking up 1 in 7 of the people that we picked up actually had what we call pre-diabetes. So they were people that we knew actually didn't have normal blood glucose, they didn't have diabetes, but they were in this mid-range. And the evidence was starting to emerge from other big studies that actually if you got people earlier, you could do something about it. And so my passion really of getting in that was from there. However, I was very interested in what we call qualitative research in those days. So I used to go around and chat to patients and realised they didn't know very much and they weren't being supported, hence that's why I have an interest in it. But also I chatted to GPs about what they thought about it. And a lot of them, interestingly, said, Jacqui, you are kidding. If you think that prevention is ever going to be on the NHS agenda, GPs won't do it unless they're paid for it. It needs to be on something called QOF. There was a time where QOF was something that meant that the GPs had to tick targets. When you had an appointment, they ticked targets and they got money, so points meant money. So actually, that was the driver. But interestingly, NHS England a few years back then actually realised that we have such a problem with diabetes that they actually have put prevention programmes on. So there is a sort of national screening programme happening, and there's always going to be flaws, but people should be invited if they're perceived to be at risk and screened early, so that you get into these programmes early rather than waiting, like you said, to be 7 years down the line when you're really anxious and upset because you know you've got diabetes and you're trying to look after yourself. So it's really tough. So I'm sad to hear that you've had that.
Yeah, no, it's not a problem for me now. I just wanted to highlight
but I mean it is. So I think the thing is if you think that you have an issue, is to sort of fight for that and go, because actually it should be much easier now in a way 7 years on, because GPs and nurses are aware of the National Diabetes Prevention Programme, or they should be.
I want to say it's more than 7 years on.
Yeah.
I've been actually diagnosed for a long time.
But I mean, it was pretty awful. And the problem is, I mean, you can do these screening things. So you could do a screening thing. You could go on Diabetes UK, do an at-risk thing and say, actually, this score says I'm high risk, and the recommendation is I need a blood test, because that's your evidence base to go. So that's a good tool you could use. Usually, you don't actually get symptoms until you're actually really definitely having diabetes. So that's very unfortunate that they missed that, because actually normal blood glucose, if I pricked all our fingers, it would rarely go lower than 3.5, not much more than 8, 2 hours after. So you don't actually get symptoms of type 2 diabetes until your blood glucose levels hit about 10. So if you're just under 10, you may be going around feeling absolutely great, but you may not have diabetes, but you may have what we call borderline diabetes or pre-diabetes and are at risk. So once you get symptoms, you really do need to go and say, can somebody give me a test, please? Because that means your blood glucose levels are probably over 10. Okay? So being thirsty is one way that the body tries to get rid of the glucose, and consequently then you're weeing a lot. Interestingly, the first thing that happens is actually you wee a lot and then you drink more. Most people think I'm drinking a lot, so that's why I'm weeing. But once the blood glucose hits about 10, your kidneys throw it out down the toilet. So if you're weeing a lot because your blood glucoses are higher than 10, you then drink more. So the weeing is the first sign, the drinking is the second, actually. So getting up in the night, that's a symptom of diabetes, being very thirsty. Feeling very knackered. You're knackered because you're peeing out glucose. Glucose is meant to be being used in every cell of your body for energy. So if it's not getting where it's meant to go, it just goes down the pan. So people feel tired. They can lose weight. Not a lot of people lose weight. Type 1, you will lose a massive amount of weight because actually you've got no insulin production, so then you just melt, basically. You might feel a bit poorly. You might get blurry vision because, again, if your glucose is high in your blood, it tends to be high everywhere, so it affects your vision, so you can pick it that way. Some people get recurrent thrush or urinary tract infections because of the glucose and dark, wet, warm places like bugs. So you get all those things together. If you are being diagnosed, nowadays they do, has anybody ever had a glucose tolerance test where you drink Lucozade? Yeah, we used to do this test, it used to be the way of diagnosing diabetes that you had a fasting test, so you weren't allowed to do anything overnight, then you came in, had a blood test that was fasting, you drank a certain amount of Lucozade, and then 2 hours later you had another test. They used to diagnose everybody that way. However, you took a lot of space up in waiting rooms, and it wasn't actually a particularly pragmatic way of doing it. So now they do a quick blood test called an HbA1c, which measures what your sugar's been like over sort of 8 to 12 weeks. And that you can't be diagnosed off one test if there's no symptoms, you need 2. So if in doubt, go to GPs. But the interesting thing is that we have this condition now that we can pick people early, and they're said to be high risk of developing type 2 diabetes or having pre-diabetes. So if we get people early, we can prevent them now moving on to get diabetes.
So can I ask a question? You need 2 tests if no symptoms present, and so are those done a period of time apart, and what's the period of time?
Yeah, they really don't want to leave it too long to do it, because the A1C is a reflection of 8 to 12 weeks, so it would be better to do it and then probably do it a couple of weeks after, really, because you don't want people to have 3 months and then, well, you could do it and it goes away, but it's not diagnostic.
Yeah, no, I was just wondering whether they set a minimum time or
they haven't really. No.
So if somebody was feeling that they had the symptoms, then they could put pressure to have it within the 4 weeks.
Oh gosh, you could have it. Yeah. You could just go to your GP, and actually they can do that test any time of the day, so you don't have to fast. So it's a nice, easy test. However, sometimes they just do a fasting test because they want to be careful, and if they're really not sure, they could do a glucose tolerance test, but they don't do that traditionally nowadays unless they suspect there being a problem that we need to look at. So can you avoid getting diabetes? Well, type 1, actually no. There's absolutely nothing you can do. If type 1 diabetes is what you have, there's nothing you can do. But type 2 diabetes now, the good news is now that in many cases we seem to be able to prevent that. It depends on how you present, really, at what stage you present, and actually whether you're a very, very thin person or whether you're somebody that's got a bit of scope for doing something. And also how many modifiable and non-modifiable risk factors you have. So there's actually, this won't mean an awful lot probably, but it just shows that there's been an awful lot of studies that have happened looking at whether we can do anything about it. And if anything goes on this side of the line, it means, yes, you can do something about it. And so you can see that there's a lot of dots on this side, which means actually there is things you can do with diet, things you can do with exercise, and things that you can do with diet and exercise. So it's worth investing in trying to do something if you think you're at risk or you've been diagnosed already as being at high risk. What can you do? And we can sort of talk about it and personalise it a little bit more via your questions in a bit. But activity, we've got the physical activity guys here because actually nowadays we are understanding so much more about being active and moving more, and even just standing. Would you believe the researchers in Leicester that I work with are getting, people just break their sitting time actually affects your risk and your health generally of dying of anything, actually. Would you believe it? One of my colleagues also says now it depends on the speed of your walking as well. So if you're a brisk walker, you're more likely to do really well than somebody who saunters. So any movement, there's guidelines, but actually wherever you're starting at, just do something a bit more. If you can't and you're in a chair, then even just having a few cans of baked beans or some stretchy bands. It's just about finding something that you can do that you enjoy to keep yourself going. Yes, we've got guidelines. Wouldn't it be great if we all, walked X amount or did so many steps? But actually the main thing is to think about where your starting point is and setting yourself some goals to move further. There's a lot of stuff now about weight. Now, weight isn't easy to lose. However, if you can be successful with it, it actually is amazing what you can do. So in a lot of the big studies, they've said that if you can lose between 5 to 7% of your body weight, you reduce your risk of developing diabetes by about 58%. So that means if you're 100 kilograms, what would that be in stones? If you lose 10 kilograms, which is about 1.5 stones, is it? Something like that, actually then you can reduce your risk. So losing weight, even if it's a small amount over a period of time, can be useful. So it's worth giving it a crack. Eating a healthy, balanced diet. Now, we all can have a lot of arguments about what a healthy, balanced diet looks like now, but it's actually one that is not excessive in any one thing. What we know is that if you need to lose weight, actually there are many ways to skin a cat. And actually it's finding the diet that works best for that person to lose the weight, rather than getting obsessed about should it be low carb, should it be high carb, should it be low fat, should it... I'm going to make my fortune. One day you're going to see my book that's a Mars bar diet, and you will lose weight on my diet, because I will let you have 3 Mars bars a day and 2 big bowls of salad. And you'll lose weight on that. And some of you are going to love my diet, but some of you will hate it. Some of you will be able to keep to it for a little while, and some of you can stay lifelong. However, some of you will have poorly bones after a long time of my diet, and some of you won't. So there's pros and cons of diet, but actually if your remit is that you want to lose weight, and you want to lose it quickly, it's actually how is the best way for you, because we know some men like eating lots of meat, and they do very well on an Atkins diet. However, some people like, or a low carb Atkins type diet, and some people actually like carbs. So it's about working with yourself or your healthcare professional, working out what fits you best. And if you're losing weight, it's actually more important if you're overweight to lose weight than to do nothing at all. And I think that's how things have changed a lot lately in the latest guidelines, rather than saying that everybody's the same. It's about finding out what works for you. But it should be nutritionally balanced, and think that actually you want to be healthy in all aspects of life, not just about diabetes. So if you cut out all fruit and veg, well, hey, you won't be that healthy. If you never have any fat in your diet, well, you do need some fat, because it gives you fats, soluble vitamins and certain things that you need for cell structure. The main thing for you is to set yourself something that you can work towards. So you're setting yourself a goal of where you're going over a period of time, but that you're making that something that actually is achievable in the short term. So that if you can achieve something and be successful at something small, then over time you're more likely to keep cracking on at it. Having a plan helps. So often we start off on something with no plan at all. I think you were talking about people are going to have their own budgets and plans potentially from the government, is trying to get us all to be so keen about our own health that we'll all have our own budgets to plan how we're going to spend it. Now, some of us will love that, and some of us will actually think, oh, I don't like that very much, I want someone to sort it out for me. But the main thing is enlisting support from wherever that might be, whether it be people like yourself, whether it be friends, whether it be family, whether it be your GP, whether it be your nurse. And getting that support to help you sustain those changes. In terms of we're looking at risk and prevention, there's support out there now, and it wasn't there before. So we've got global and national recommendations now saying that we need to identify and prevent people developing type 2 diabetes by screening. So this is from NICE, on government high, telling us to do that since 2012. But the programme now, we have a national diabetes prevention programme in the UK called Healthy You. And some of you may have got called up to go to this programme, but it's a programme that is running up and down the country that you go to over, I think it's over, I should know because I wrote anything. So it's over about 10 weeks, but it's they've done that over like a 9-month programme. Lots of people don't like groups, so they've actually also now put in a call out for a digital programme. So they're trying to make this be embedded now into UK NHS. Other sources of support, there are weight loss programmes that you can go to if you want to go to those. There are ones that are led through the NHS. There are online programmes now if you're interested. You can get referrals to a dietitian. If you live in Loughborough, there is a very good service in Loughborough at the hospital or within certain community areas. There are exercise specialists that we never used to have so much before. There's exercise on prescription. There's people that you can go and see to do that. And one of the major sources of stuff, if you like looking at the internet, is Diabetes UK. So that is a website that is there. So if you want any information, that is a good source of information for you. And they also will talk to you if you want to call somebody up just for a chat and say, I don't know what I'm doing. They have a care line now. So they've changed a lot in the last few years, I think, really, in terms of trying to look after people and support them. So we have got a possible prevention. We've got possibilities for being at risk, but even if you now get diabetes, the latest evidence is, and I don't know how good I'd be at it, but actually, if you've got type 2 diabetes, we used to say it can't go away. Now the evidence is if you can lose 15 kilograms, if you're a big person, that's quite a lot to lose. And however you can do it, whether it be a commercial diet, Rosemary Connolly or whatever, 15 kilograms, you can reverse your type 2 diabetes. we used to say you can't do it, but for some people they want to do that. If you start off thin though, there's nothing you can do. You have to think, well actually I can stay active, and thank goodness you carried on so long, otherwise you'd have had diabetes when you were younger. So people who get diabetes when they're slimmer, often it's they've done well holding it, and they would have been younger getting it, they hadn't have done so well for so long. So it's finding the right path for you. So I can't say that enough really about being individualised care, not one size fitting all anymore.
And even if I had reversed my diabetes, but then if something changes which is out of your control, it can go back again, and then it feels like it's a bigger fight to get back on top of it.
Yes, because you're juggling a lot of balls all the time, aren't we? We're juggling lots of things, and sometimes diabetes or your health is important, and sometimes family is more important, or finance, or holidays, or whatever. So it's really about juggling constantly to sort of keep your health going, really. Fantastic. So any questions now from those of you that have come for with an agenda at all? Anybody got any diabetes?